Today we are going to discuss about the echocardiographic evaluation of pericardium. Let us start with the anatomy of pericardium. Pericardium has two layers. One is visceral and parietal, a second is parietal. Visceral layer is made up of mesothelial cells, collagen and elastin fibers, while parietal layer is made up of the collagen and elastin fibers. Visceral layer reflects back over the origin of the great vessel, and so that the left atrium is largely extrapericardial. Normally there is 5 to 10 ml of pericardial fluid within the pericardial space, and pericardium serves to restrain the 4 cardiac chambers within a relatively confined volume and space within the thorax. Etiology of pericardial diseases. Pericardial disease can be idiopathic, which could be acute idiopathic pericarditis, chronic idiopathic effusion, can be infectious disease, viral pericarditis, bacterial pericarditis, most commonly in our country tubercular pericardial involvement with pericardial effusion or constrictive pericarditis, other bacterial infections, fungal infections. Pericardial disease can be inflammatory in origin, maybe due to some connective tissue disorders like rheumatoid arthritis, SLE and others. Pericardial effusion may develop post myocardial infarction acutely after transmural infarct, or maybe due to free wall rupture, which may be partial or complete, and delayed pericardial effusion may develop in Dressler syndrome. Pericardial involvement may also occur with systemic diseases like uremia in patients with chronic kidney diseases, hypothyroidism, pregnancy, cirrhosis. Even malignancy can involve pericardium. It may be just like development of pericardial effusion or direct tumor involvement. And other miscellaneous causes of pericardial involvement are trauma, post-surgery, even congestive heart failure, and in cases of the pulmonary hypertension, in right heart failure, patient may develop pericardial effusion. So, echocardiographic evaluation of the pericardium can be done by using M mode, 2D echocardiography, 3D echocardiography, or by intracardiac ultrasound. Let us start first with the pericardial effusion, which is most common disease of the pericardium, and the diagnosis of the pericardial effusion is usually made when we see a echo-free space which separates the visceral and the parietal pericardium, and which that echo-free space remains throughout the cardiac cycle, even during the diastole. And echo-free, when I say that echo-free space, it means that there is an echo texture which is similar to that of the intracardiac blood pool. So, this is an image. On the left side we can see that there is no pericardial effusion, and we usually look for pericardial effusion behind the posterior wall of the left ventricle. And on the right side of the image, in image B, we can see that there is some echo-free space which we can see in posterior to the left posterior wall. So, that is present in the diastole. We can see the mitral leaflets are opened. So, the echo-free space which could only be seen in diastole and which could only be seen in systole and which could not be seen in diastole. That means that there is minimal pericardial effusion. So, when there is minimal pericardial effusion, it will not be present throughout the cardiac cycle. It will only be present when the left posterior wall is lifted off the pericardium during the systole. So, this is a normal phenomenon. Normally also minimal pericardial effusion may be present, but see in the now here in the image A, we can see the pericardial effusion which is small, but it is present throughout the cardiac cycle, even though it is seen more in the it is seen more in the systole, but even it is present during the diastole. And in the image B, we can see there is slightly higher volume than the left sided images. Means there is a slightly bigger pericardial effusion, and even there is respiratory variations are seen in the right ventricular chamber. Quantification of the pericardial fluid, usually size of that echo-free space, it is directly proportional to the amount of the fluid present in the pericardial cavity. So, MO technique which we use, they can say about the amount of the fluid, but they are not that accurate in quantifying the absolute volume. So, if there is minimal pericardial effusion, that as we discussed, that is normal, and that can only be seen during the systole of the cardiac cycle. And small pericardial effusion, which is seen throughout the cardiac cycle, and it is quantified like there is 1 centimeter of posterior echo-free space with or without the accumulation elsewhere. Moderate pericardial effusion is when there is a 1 to 2 centimeter of echo-free space posterior to the posterior wall of the left ventricle, and large effusions we say when there is more than 2 centimeter of the separation, more than 2 centimeter of the echo-free space is seen. So, this is a small pericardial, this image shows the small pericardial effusion. Next image, this shows a large pericardial effusion. This is again the upper image shows small pericardial effusion, and the lower image shows moderate pericardial effusion. Here again the image shows moderate pericardial effusion with that echo-free space, the dimension is showing that it is 18 centimeter. It is large pericardial effusion. This is again an image showing pericardial effusion lateral to the left ventricle, and even near the right side of the heart. This is an image which shows predominantly loculated pericardial effusion, where we can see pericardial effusion lateral to the left ventricle, and this usually happens in cases post open heart surgery. We should also give importance to the characteristic of the pericardial fluid on echo. We may find the fluid in the pericardium clear, or there may be stranding which suggests inflammatory etiology or the hemorrhagic etiology. So, in this image we can see stranding arising from the parietal and visceral pericardium. Even pericardial hematoma can be diagnosed, and pericardial hematoma usually happens due to bleeding within the pericardial space. So, it can be post open heart surgery or post trauma, or due to myocardial rupture, aortic dissection, or post catheter based intervention. And usually hematoma looks more like clot than the free fluid, and it is more reticulated and more echo-dense than that of the free fluid. It may be unevenly distributed, and it may be localized to the bleeding site. So, this is an image showing hematoma towards the right side of the heart, and possibly there is a right ventricular free wall rupture, and we can see that hematoma is sealing that place. Again an image showing hematoma within the pericardial cavity. Hemodynamic consequences of pericardial effusion can also be diagnosed echocardiographically. So, we can diagnose definitely on echocardiography when patient develops cardiac tamponade. Echocardiographic markers of cardiac tamponade, they fall into two categories. One is like cardiac chamber invagination, which reflects that there is increased in the intrapericardial pressure, and that pressure is invaginating the chambers. So, that pressure within the pericardium is more than the pressure within the chambers, that can cause cardiac chamber invagination. And even echocardiographic marker of pulses paradoxus, which means that there will be exaggerated respiratory variation in the left side of the heart filling and ejection relative to that of the right side of the heart. And signs of this increased intraparietal pressure, there will be diastolic, early diastolic RV outflow collapse and exaggerated right atrial collapse during the late diastole during the atrial systole. The earliest description was of this right ventricular outflow tract collapse was obtained using the M-mode echocardiography, and where it was shown where characteristic posterior motion of the right ventricular anterior wall was noted in the diastole. So in this image we can see that M was put, and there was a posterior movement of the right ventricle wall during the diastole. Here also this is a mode image which shows the diastolic collapse of the right ventricular outflow tract. And let us just discuss why this early diastolic RVOT collapse happens. It happens due to increase in the intrapericardial pressure, and during the early diastole, intracavitary cardiac pressure, it transiently falls, and it falls below intrapericardial pressure in the early diastole, and that lead to the hemodynamic compression of more distendable structure like right ventricular outflow tract during the early diastole. So, and also anatomically and experimentally, the right ventricular outflow tract is the most compressible area of the right ventricle, and so with significantly elevated intrapericardial pressure, it tends to collapse. So in diastole, immediately after closing pulmonary valve, at the time of the opening of the tricuspid valve, the right ventricular outflow tract will paradoxically collapse inward, and when the collapse extends from more compressible outflow tract to the body of the right ventricle, it suggests that intrapericardial pressure is even elevated more. Sensitivity of this test means RVOT collapse is 82 to 94%, but the specificity is more, it is around 88 to 100%. This is an image showing normal distension of the RVOT during the systole, and in the lower image we can see the diastolic collapse of the RVOT during the early diastolic period. Again this image nicely shows the collapse of the right ventricular outflow tract during the early diastole. Similarly, RA inversion also happens, that due to raise in the intrapericardial pressure, and RA pressure is minimum during the late ventricular diastole. So during the late ventricular diastole, RA inversion happens in cardiac tamponade, and the sensitivity of RA collapse is 100%, while the specificity is less, 82%. And there is also one index which is called RA time index, and it is calculated it is calculated as the number of the frames during which the right atrium is inverted divided by the number of the total frames per cardiac cycle. So that if it is more than or equal to 0.33, it is considered as significant cardiac tamponade, hemodynamically significant pericardial effusion, and which has sensitivity of 100% and 95% of the 95% of the sensitivity and 100% specificity. So in this image also, in the lower image we can see the collapsed RA during the late diastolic phase of the cardiac cycle. Other Doppler findings in tamponade are normal respiratory variations like In mitral valve, normal respiratory variation is around 15%. In tricuspid valve, it is 25%. In aortic and pulmonary valves, it is within the 10%. So, if it goes beyond that, if there is more than normal respiratory variation in the inflow peak velocities, it suggests cardiac tamponade. There will be exaggerated variation. So, here we can see exaggerated variation in inflow velocities of tricuspid valve and mitral valve, also even pulmonary and aortic valve showing the means LVOT, they are showing the exaggerated respiratory variations, which suggests there is hemodynamically significant pericardial effusion and patient is in cardiac tamponade. And what happens to the vena cava and hepatic vein flow during the tamponade? So, usually vena cava flow occurs throughout the cardiac cycle, so means in systole and diastole. But when there is elevated intrapericardial pressure, flow during the diastole is truncated and majority of the flow happens during the ventricular systole. And the hepatic vein flow pattern will reflect the exaggerated respiratory phase. Here we put the cursor in the hepatic vein, and pulse wave Doppler is showing that the flow happens only during the inspiration, and it is confined within the inspiratory phase only, while there is no flow, loss of forward flow in hepatic veins during expiratory phase of the respiratory cycle. So, it happens in cardiac tamponade. Even echocardiography helps us while we do pericardiocentesis. It gives us idea where to puncture for pericardial effusion. Even we can confirm our needle in the pericardial space while performing a procedure, and we can document reduction in the pericardial effusion post tapping using echocardiography. Next most common disease after this pericardial effusion is constrictive pericarditis, and in classic constrictive calcific constrictive pericarditis, pericardium forms a rigid shell in which the cardiac chambers are encased, and therefore they will not be affected by any change in the intrathoracic pressure. We will go into the pathophysiology of the disease also. So, constrictive pericarditis happens due to scarring and due to loss of the normal elasticity of the pericardial sac, and so it leads to the impairment of the ventricular filling in mid and late diastole. As a result, the majority of the ventricular filling happens during the early diastole, and then the ventricular volume does not increase after the end of the early filling period. And also one of the characteristic finding we find in constrictive pericarditis is ventricular interdependence. When I say ventricular interdependence, it means that filling of one ventricle limits the simultaneous filling of other ventricle because of the shared mechanical constraint. So, key factors in pathophysiology of the constrictive pericarditis are: one is marked restriction of the filling, as we discussed that filling only happens during the early diastole. There will be ventricular interdependence due to shared mechanical constraint, and failure of the transmission of the intrathoracic pressures to the intracardiac chambers. This image shows the ventricular interdependence. So, we can see that during inspiration there is a decrease in the LV pressure and LV volumes, while there is increase in the RV pressure and volumes, and the opposite happens during the aspiration. So, the ventricular pressures are discordant. Normally, there will be a decrease in the intrathoracic pressure, which is transmitted to the all cardiac chambers, and this decrease during the inspiration, the intrathoracic pressure which has decreased, it will cause decrease in the pressure in the pulmonary veins and also the left ventricle. due to transmission of the pressure to the cardiac chambers. And so this decrease in the pulmonary capillary wedge pressure, which is accompanied by corresponding decrease in the LV pressure, which will lead to the gradient which will drive the LV filling. But during the constrictive pericarditis, that pressure which decreases during the inspiration, intrathoracic pressure, it will not be transmitted to the LV, but it will be transmitted to the pulmonary vein and LA. We discussed previously only that left atrium is largely extrapericardial. So the decrease in the intrathoracic pressure will be transmitted to the LA, but it will not be transmitted to LV. So there will be less gradient which will drive the inspiratory LV filling. So there will be decrease in the LV filling during the inspiration, and so the IVS will shift to the left and it will allow increased RV filling, and it opposite happens during expiration. So in constrictive pericarditis, during inspiration there will be decreased transmitral gradient, so there will be decreased LV filling, but there will be increased flow across the tricuspid valve, and there will be more RV filling during inspiration, and opposite will happen during expiration. Constrictive pericarditis can be diagnosed echocardiographically by M mode also, and the characteristic of the pericardium can be seen on echocardiographically. Even like normal pericardial thickness is 1 to 2 millimeter, and additional indicators of thickened pericardiums are like persistence during the gradual damping of an M mode beam through the posterior left ventricular wall. I have an image also that I will show you. And if there is calcific pericardial disease, the ultrasound shadowing may occur, and it gives hint that there may be constrictive pericarditis as an underlying pathology. So direct visualization of the pericardium, we can see calcification, even can see fibrosis, thickened pericardium can be seen, and in presence of calcific pericarditis there will be shadowing which will be seen posterior to the pericardium. In M mode we can find some other abnormalities apart from thickened pericardium. There will be abrupt relaxation of the posterior wall with subsequent flattening of the endocardial motion throughout the remainder of the diastole, and there will be abnormal septal motion. Septal bounce will be seen on M mode. So this is an M mode image, and here there is one area which is marked by black bracket, where damping has been increased to suppress the fainter posterior there is a wall posterior myocardial echoes, but still brighter pericardial echo they cannot be suppressed. So if we cannot suppress this pericardial echo, it suggests that it is constrictive pericarditis. Even in this image we can see that flat motion of the posterior wall, arrow is showing that flat motion followed by sudden rapid posterior motion. So sudden rapid posterior motion is shown by an arrow, and then we can see the flat motion of the posterior wall of the left ventricle. So why septal bounce and what to see when we look for septal bounce? So typically when we put M mode, we can see early diastolic notching followed by paradoxical septal movement, and then the normal septal motion of the ventricular septum. And this septal motion, it reflects the competitive filling, it suggests the ventricular interdependence, and even within the atrial systole there may be exaggerated motion of the ventricular septum as well. So in this image we can see that there is a diastolic notching of the ventricular septum, followed by there is paradoxical septal motion, and then there is normal septal motion. And the final indirect sign of constriction is dilatation and lack of respiratory variation of the IVC diameter. So here there is a lack of respiratory variation in the IVC diameter, and IVC is seen dilated here, which is 24.6 millimeter. Even other echocardiographic findings like Doppler findings in constriction, exaggerated E by A ratio of the mitral valve inflow with a short deceleration time, exaggerated respiratory variation in E wave is a reliable sign of the pericardial effusion, and variation of more than 25% or more than 25% in the mitral valve E wave velocity, which is seen between inspiration and expiration, it has been considered abnormal. So here respiratory variation is higher, which suggests constrictive pericarditis. So respiratory variation of more than 25% in mitral valve suggests constrictive pericarditis. Even on tissue Doppler, the peak E dash of more than or equal to 8 cm per second suggests constrictive pericarditis, which has almost 100% of specificity, and other additional markers for constrictions are premature opening of pulmonary valve, which is which happens more with inspiration, which suggests there is an increase end diastolic rapid rise in the RV pressure that exceeds the pulmonary artery pressure, and which will lead to the premature opening of the pulmonary valve. Other findings are the diastolic MR and expiratory diastolic hepatic vein flow reversal. So, and this classical finding of constriction are usually most prominent when the patient is euvolemic. So if the patient is hypovolemic, we should load some volume and then check for the findings of pericardial constriction, and if the patient is overloaded, then head up tilt test help in unmasking the classic findings. Effusive constrictive pericarditis is a combination of effusive and constrictive physiology, and this diagnosis is often established when hemodynamic compromise and moderate pericardial effusion involve the jugular distension hemodynamic compromise, which persists even after pericardiosynthesis. After pericardiosynthesis, the effusive component will resolve and hemodynamics will appear more similar to constriction in cases of the effusive constrictive pericarditis. If we want to differentiate it from the restrictive cardiomyopathy, there are certain differentiating features in constrictive versus restrictive physiology. So one of this is mitral annular Doppler tissue imaging, which is E dash. Here we can see that E dash is 28 cm per second. So that is a distinguishing feature when we want to differentiate it from the restrictive physiology. And another method of differentiating is by looking at the velocity of propagation of the mitral inflow when we use the mitral color Doppler M mode imaging, and the velocity, if that velocity is normal or higher, it suggests constriction, while if the velocity is reduced, it suggests restrictive physiology. So in this image we can see that there's a velocity propagation is more than 200 cm per second, so which is suggestive of constrictive physiology. So these are various parameters to differentiate constriction from restriction. Atrial size is usually normal in constriction, while in restriction atrial dilatation will be seen. Pericardial appearance is thick and bright, while in restriction it is normal. Septal motion is abnormal during constriction. We can find other motion abnormalities which we discussed previously on M mode, while in restriction the septal motion is normal. Septal position varies with the respiration in constriction, while it remains normal in restriction. Mitral E by A ratio is increased in both the cases, and the deceleration time will also be reduced in both the cases, while annular EM is normal in constriction while it is reduced in case of restriction. Pulmonary hypertension is rare in constriction while it is very common in restriction, and LV size is usually normal in both the cases. MR and TR is frequent with restriction while it is less common with constriction. Isovolumetric relaxation varies with respiration in constriction while it is stable with respiration in restriction. Exaggerated respiratory variation of the mitral E velocity will be seen in constriction while it will not be seen in case of restriction. And color M mode mitral velocity propagation will be increased or normal in case of constriction while it will be reduced in patients with restrictive physiology. The differentiating features between constrictive pericarditis and restrictive cardiomyopathies: septal bounce is less, it doesn't happen with RCM, it happens with constrictive pericarditis. Mitral inflow respiratory variation will be more than 25% in constrictive pericarditis, while there will be no respiratory variation in mitral valve inflow. In tricuspid valve inflow, more than 40% of the respiratory variation will be seen in CP, while there will be no respiratory variation in restrictive physiology. Deceleration time will be short in both the cases, while hepatic vein reversal, it will be seen with expiration in constrictive pericarditis, it will not be seen in restrictive physiology. And also the E by E dash ratio, it will be less than 8 to 10, while it will be more than 15 in restrictive cardiomyopathy. So it's suggestive of the diastolic dysfunction. So in restrictive cardiomyopathy, that E by E dash ratio is more than 15, while in constrictive pericarditis it will be less than 8 to 10. Let us discuss about the other abnormality of the pericardium, which is congenital absence of the pericardium. Here we cannot see pericardium at all. So we will have to suspect it when we see a leftward shift in the position of the heart and somewhat dilatation of the other chambers of the heart. And due to lack of the pericardial constraint, there will be abnormal position of the cardiac Silhouette and even mild degree of the right atrial and right ventricular dilatation. And sometimes paradoxical septal motion can also be seen in cases of the congenital absence of pericardium. Pericardial cysts, they are usually they are benign and they are developmental anomalies which occur near the costophrenic angle. Usually it happens adjacent to the cardiac border, and most commonly it is seen near right atrium. In this image we can see a pericardial cyst near right atrium. And last is malignant involvement of the pericardium. That malignant involvement may happen malignant involvement may be like development of pericardial effusion, or there may be appearance of the tumor which extends into the myocardium. Usually this primary pericardial tumors, they are very uncommon, they are less common, and this malignant involvement of the pericardium is mostly in form of pericardial effusion due to local or the distal metastasis, and usually it happens with lung cancer and breast carcinoma. Thank you.